What do you see here? Here, if you zoom and see, they are passing a syringe and the syringe is directly touching the placenta. That means they are trying to take the chorionic villi, right? So, this is a chorionic villus sampling. Okay. So, this is a picture of chorionic villus sampling. Okay. This is usually done in the first trimester and you can do it via two ways. Okay. So, it can be done through a trans-abdominal route also or trans-cervically also, as they have shown in the picture. So, when you do trans-abdominally, you will be passing a 18 to 20 gauge spinal needle, right. Suppose if it is done trans-cervically, then you will be passing a polyethylene catheter. Okay. So, whole procedure should be done aseptically and it will be mostly done between 10 to 13 weeks of gestational age, and the indications of doing chorionic villus sampling include so many indications, mostly common for your amniocentesis and chorionic villus sampling. So, it can be to detect genetic or chromosomal, even metabolic infectious pathology like that. Okay. And relative contraindications of doing this procedure, or when the woman has already any infection or any vaginal bleeding like that, right. Okay. There is chance of miscarriage in this procedure up to 2%, and you will also be able to see limb reduction defects and hypogenesis. If it is done much earlier, okay, when they plan it much earlier, early CVS like before 7 weeks or like that, okay. So, this is all about chorionic villus sampling, right. And now, what you are able to see here, the syringe is taking amniotic fluid. So, this is your amniocentesis. So, amniocentesis is usually done between 15 to 20 weeks of gestational age. Here the pregnancy loss is very less, it will be only up to 0.5% and there can be vaginal spotting also. So, the same causes what we have mentioned before, and you have to know another important point, whether you do chorionic villus sampling or amniocentesis, if the mother is going to be Rh negative woman, you have to definitely give her anti-T, right? Yes. And yes, let us see this picture. So, what is this? Here the syringe is in the cul-de-sac, yes, pouch of Douglas, and they are aspirating the fluid that is present in the cul-de-sac. So, what procedure is this? This is your cultocentesis, right? This is your cultocentesis, okay. So, this procedure is obsolete, we are not doing it anyhow, but you should know, okay, where it is done. So, usually what they do is, they use a syringe and collect the fluid or blood, whatever it is collected in the pouch of Douglas, and they will be testing it, right. Suppose if they are getting clotting blood, that means it is a positive test, right, and it is an indication of surgery, in which case they do to test if there is a ruptured ectopic or not, okay. But the disadvantage of this procedure is, the ruptured thing can be either an ectopic or it can be a corpus luteum. We will not be sure about this just by seeing the aspirated blood, right. So, this is obsolete now, right. Okay. Now, we are going to study about amniotic fluid, right. So, amniotic fluid. First, let us speak about the source. Amniotic fluid is actually secreted from the amniotic epithelium, and by 10th week, this will be formed by the transudation from the fetal serum that will be happening through the fetal skin. Then by 20th week, this is formed from fetal urine, because the fetal skin by this time becomes impermeable, right? Yes. Now let's talk about the amount of amniotic fluid at various gestational age. So at the amount of amniotic fluid at various gestational age, so it is around 30 ml at 10 weeks, then 300 ml at 20 weeks, 600 ml at 30 weeks, and by 36 weeks it is 1000 ml, and by 40 weeks it will reduce again to 800 ml, and it will be further reduced to only around 200 to 300 ml if it is around 42 weeks. So the point you have to keep here is maximum amount of amniotic fluid is seen at 36 weeks. Clear? Right. And let us also talk about something on the color of amniotic fluid. Okay, so the different colors of amniotic fluid. So normal color of amniotic fluid is colorless. Okay, and at term you may see some exfoliated cells and lanugo hairs along with it, but normally it is colorless, right? And the next one, it can be saffron color, okay, that is somewhat greenish in yellow color in case of postdated pregnancy. And when you have green color, that is a meconium stained like you have to suspect fetal distress. Then we can have reddish dark color when there is contamination with accidental hemorrhage. It can be golden color. Golden color amniotic fluid is seen in orange incompatibility, because there is excess bilirubin that is arising from the hemolysis, right? Or is incompatibility. And then it can be dark brown in color, that is tobacco juice color in case of intrauterine fetal death. Okay, so these are the various color of amniotic fluid and the conditions you have to think about when you see the different color, right? Yes. Now we have to talk about two important conditions when talking about amniotic fluid. Yes, it is going to be a polyhydramnios and oligohydramnios. So let us talk about polyhydramnios first. So polyhydramnios is a term used when amniotic fluid is excessive. Okay, so here excessive means it is more than 2000 ml, and amniotic fluid index will be around 25 centimeter in this case, and single vertical pocket will be more than 8 centimeter, right? So it becomes more for the 95th centile for that particular gestational age also. And what are the important causes of polyhydramnios? So this will include your fetal causes like anencephaly, Spina Bifida, esophageal atresia, okay, even in your multiple pregnancy like that. And maternal causes of hydramnios are also there, which will include diabetes and preeclampsia like that. And placenta causes of hydramnios include your hemangioma, and sometimes it can be idiopathic also, right? Now let's talk about oligohydramnios. So opposite to polyhydramnios, oligohydramnios means diminished amniotic fluid, right? There is diminished amniotic fluid. It can become even less than 100 ml, or even it can be absent also, Okay. So, actually A5 becomes less than 5 centimeter or single vertical pocket becomes less than 2 centimeter, that means oligohydramnios. And the most common cause of oligohydramnios is renal agenesis or any obstruction in the urinary tract, because we have seen after one particular stage, that is by 20 weeks of gestation, it is going to be the fetal kidneys which is going to produce the amniotic fluid, right? So, it is the first affected if there is oligohydramnios. Then also you have to think about other causes, like it can be IUGR that can be associated with a placental insufficiency or postdated pregnancy. It will be less, right? We have seen how the quantity will reduce. Then there can be premature rupture of membranes as well as amniotic nodosum. Okay, so these are some of the causes, and remember the most important cause of oligohydramnios is renal agenesis, right? Yes. Now let us see this ultrasound picture. So this is how amniotic fluid index is measured. Okay, so what you do is you divide the abdomen into 4 quadrants. Okay, so it is divided into 4 quadrants by using the linea nigra as well as a transverse line that is drawn to the umbilicus. Okay, you will get 4 abdominal quadrants. Now you have to measure each vertical pocket in each of the quadrant and make sure that there should not be any fetal parts or placenta or nothing should be present. Okay, only the amniotic fluid pocket you have to measure, like how they have shown here. And finally what we will be doing is we will be adding all these 4 packets and finding a value. Okay, so in that only we have seen the ranges between 5 to 25, right? So if it is less than 5, it is going to be oligohydramnios. If it is more than 25 centimeters, it is going to be polyhydramnios, right? And a single deep vertical pocket means one long vertical pocket will be measured. Okay, so the cutoff here is 2 to 8. So less than 2 it is oligohydramnios, above 8 it is going to be polyhydramnios. Is that clear? Right. Now let's talk about some of the early signs of pregnancy. Okay, so what you are able to see here is a gestational sac. Okay, so that is present in the decidua. Okay, so this is otherwise known as intradecidual sign. Okay, so this is usually seen at 4.5 weeks by transvaginal ultrasound, and it is eccentric to the central echogenic rim. Okay, so this is the rim actually, so it is echogenic to the central echogenic rim, right? And it has a thin rim surrounding it also. Okay, so this is a intradecidual sign. When you see a single small dot like thing, then it is a intradecidual sign, right? Next one is this sign. So this is a double decidual sac sign. Double decidual sac sign. Okay, so this sign is seen at 5 weeks and it is seen as a rounded or oval fluid collection. You have 2 rings here. Okay, so that is why it is called as double decidual sign. 2 echogenic rings you have. Okay, so the outer ring is by the decidua and the inner ring is by the chorion, right? And with this you should be able to understand that difference should be made between the early intrauterine pregnancy and a pseudo sac. Okay, so normally the sac will be situated below the midline and it will be buried into the decidua in a normal intrauterine pregnancy, whereas in a pseudo sac it is midline and it is present exactly between the endometrial layers, right? And the shape of a normal sac is circular and steady, whereas a pseudo sac is elongated and it varies during the scan also. And the border is double border. Just now we have seen how the echogenic film is there, right? But here it is only a single decidual layer, and color flow, there will be high peripheral color flow in a case of normal sac, whereas in case of pseudo sac it is going to be avascular, right? So this difference is also important. Next that comes after gestational sac is yolk sac. Okay, so a yolk sac will be seen at 5.5 weeks, and when you see yolk sac inside a gestational sac, then it confirms your intrauterine pregnancy. Okay, so this is the importance here, right? I don't want to speak more about it, so that is enough for you. Next, here you are able to see two rings, right? So these two rings means one is yolk sac and another one is your amniotic sac, right? So this is usually seen at 7 weeks, and remember, in the amniotic cavity lies the embryo, and in the chorionic cavity you have the yolk sac. Clear? Right. Next, this one. So seeing this, you will be able to understand that something is abnormal with the cervix, and this is another view of what has been present there. Okay, so you have the anterior cervix, you have the posterior cervix, and you are able to see the fetal head here. Okay, echogenic thing that is born. Then you are able to see the funneling of the cervix, right? There is funneling of the cervix, and there is some sludge that has settled in the os, right? So this is about cervical incompetence, right? Very good. So cervical incompetence diagnosis by ultrasonography is usually made by 14 weeks, that is usually seen in the second trimester, and it is diagnosed when cervical length becomes less than 30 millimeter. So normal range is 35 to 40, okay, sorry, 35 to 40 millimeter, right? And the diameter of internal os will be more than 20 millimeter, and there is funneling of the internal os. Okay. So always while measuring cervical length, transvaginal ultrasound is more preferred than transabdominal ultrasound, because when you do transabdominal ultrasound, bladder should be full. Okay, so this may give a false impression of a lengthy cervix also. So always transvaginal is preferred over transabdominal ultrasonogram. Okay, so this is when the woman is pregnant, we are offering her TVS and finding the cervical length. Suppose the woman is not pregnant at all, then if you ask me if it will be able to make her, she is having a short cervix during her non-pregnant statements, yes, it is possible by using Higger dilator number 8. Okay, so if Higger's dilator number 8 is passing easily, then she should be thought about cervical incompetence. She should be repeating. If Higger's dilator number 8 is passing easily means, then she should be at a risk for cervical incompetence, right? And during pregnancy, we can offer her speculum examination also. Okay, speculum examination also, where you will see dilation of cervix, and within that, yes, membranes will be protruding enough. Is that clear? Right. Now, one important concept recently they started testing you is, they are asking about the methods of cervical circulation that will be done through transvaginal route and transabdominal route, right? So let's discuss about the transvaginal circulages first. So this will include lash and lash circulage, Worm's circulage, then your McDonald's circulage, as well as your Schrothker's circulage. Okay. So transabdominal route, I am not teaching about the methods, just know the names, that's it for now, right? So it will include your Benson and Durfee method and also your laparoscopic circulage method. Okay, the question was which method is done transabdominal. They gave 2-3 options and they included laparoscopic circulage. So obviously it will be your laparoscopic circulage, right? Yes. So that's how the questions will be, right? Now this is the image where NT measurement is shown, right? So what is NT? This is nothing but a subcutaneous lucency. Okay, so that is nothing but a small pool of fluid that is situated in the dorsal neck region. Okay, and it is usually measured between 11 to 14 weeks of gestational age, and when CRL is between 45 to 84 mm. right? Now, increased NT, that is increased nuchal translucency, is usually associated with increased number of chromosomal anomalies, like especially your trisomies, right? 21, 18, and even your Turner, okay, also your cardiac anomalies or skeletal anomalies, okay, and multiple genetic syndromes also, okay. So, usually will be offering it like it will be offered either alone or it can be combined with other parameters also, okay, biomarkers also. So, we can have dual test or triple test and quadruple test, okay. So, in this dual test is offered during your first trimester, whereas triple and quadruple test is offered during your second trimester, right. So, dual test means we will be offering her beta HCG and PAPA, that is pregnancy associated plasma protein A. So, this can be combined with your NT screening. So, that is called as combined first trimester screening, right. And triple test means it is your beta HCG, then unconjugated estriol and maternal serum alpha fetoprotein, okay. So, in quadruple test, all these three things plus it is going to be a serum inhibin, okay. The components of these tests is important, okay. So, what do you see in triple test, what do you see in double test, and what do you see in quadruple test, okay. So, the easy way to remember is dual test, I remember it is B and P, okay, BP, okay, and triple test it is going to be Ha U, okay, and for quadruple test it is Hi U, that's it, okay. So, it is beta HCG, then alpha fetoprotein, then unconjugated estriol, okay. Here beta HCG, alpha fetoprotein, inhibin and unconjugated estriol, clear, right, okay. Now, let us see this image where something is missing over here, okay. So, there is some abnormality over the cranium of the fetus. So, what do you think it is? Yes, it is going to be a anencephaly. So, it is anencephaly. So, this is one of the earliest diagnosed fetal anomaly by ultrasonogram, because normally the cranial neuropore, okay, it closes by day 24 of life, but it is not closing, it will lead to anencephaly, right. So, you can also use markers for this, which is your maternal serum alpha fetoprotein. It is very highly elevated, okay, it is very highly elevated when compared to other abnormalities, okay, in anencephaly. And during the first half of the pregnancy, you can make ultrasound diagnosis also, okay. So, in that you will be able to see absence of fetal skull vault as I have shown now. Then there will be triangular facial appearance, okay. That means it is frog's eye appearance. Then you will not be able to check biparietal diameter, right, because the cranium is not there, right. So, you will not be able to check the biparietal diameter. Then absence of brain or presence of any angiomatous tissues, okay, which is not supposed to be brain, some other tissues will be present, okay. So, this failure to measure biparietal diameter is suspicious of anencephaly, and in late first trimester, this can be made out by using the shower cap sign, okay. So, in second trimester, other associated features will come, okay, because there is no brain, swelling will be defective. So, the patient will be presenting with hydramnios, okay, and even during examination, you will not be able to make out the fetal head, okay. So, all these things will be there, right. So, this is the frog eye sign where the orbital structures are seen protruding, right, and it is most commonly seen in fetal anencephaly. So, this is seen here again, okay, you are able to see the frog eye sign, right, okay. Now, what are the other associations we can have with anencephaly, right? So, we can have other neural tube defects like Spina Bifida or any congenital heart defects, cleft lip or cleft palate, urinary tract abnormalities like hydronephrosis, like that. Okay. So, what do you do to prevent anencephaly or any neural tube defect? You have to supplement folic acid 1 month before pregnancy, and it should be supplemented at a high dose, that is 4 milligram per day. Okay, and it should be continued till the end of the first trimester. So, routine doses 400 micrograms. Okay, so here we are giving 4 milligrams if there is a history of neural tube defect, right? Yes. Yes. Now, here you are able to see there is a defect, right? And something is protruding through that defect. So, what do you think it is? Yes, it is a case of Spina Bifida, and in this picture I am not sure if it is visible on the screen properly, but I will trace it out for you. You are able to see something like this. Okay, so what do you think it is? It is, yes, banana sign, and I hope this is somewhat clear, right? So, if I trace it again, you are able to see that this is the lemon sign that is seen in Spina Bifida cases, right? So, usually antenatal ultrasound has a high detection rate for Spina Bifida, and we have two signs, that is lemon sign and the banana sign. Lemon sign means it has a strong association with Spina Bifida, whereas banana sign means the appearance of the cerebellum that is wrapped around the medulla, and it is mostly seen in case of cherry malformation. Okay, so it is nothing but the cerebellum that is wrapped around the medulla, right? Yes. Next, if you see this defect, you are able to see a swelling that is present in the abdominal region of the fetus. So, definitely there is some protrusion that has come out through the umbilicus in the abdominal region, right? So, these are your gastrointestinal defects, and this is probably an Omphalocele. Okay. So, if you see, you have to think about two defects. Okay. One is Omphalocele, which will be classically round in shape, regular rounded shape. Okay. And the Gastroschisis means the bowels itself is coming out. Okay. There is no peritoneal covering or sac that is seen around this intestines. Okay. So, this is Gastroschisis, right? Now, let us see the differentiation between the both. We have Omphalocele and Gastroschisis. First, let us see the location of the defect. Okay, location of the defect is central in case of Omphalocele, whereas in Gastroschisis it is lateral. Next is, you have to see the insertion of umbilical cord. In Omphalocele, insertion of the umbilical cord will be into the sac, whereas in Gastroschisis it will be seen independently. Okay, and third point is, as I told you, membrane covering Omphalocele will be present, whereas in Gastroschisis it is absent, and ascites will be seen, may be seen in case of Omphalocele, but it is absent in case of Gastroschisis, and associated chromosomal anomaly is mostly seen with Omphalocele and it is not seen with Gastroschisis. And finally, the organs that can be seen in case of Omphalocele can include organs like bowel, liver, stomach, etc. Whereas here in Gastroschisis it is only your small bowel. Okay. So, bowel complications are more with Gastroschisis. Okay. So, this is how we have to differentiate it, right? Okay. Now, what is this sign? This is a, yes, very good, keyhole sign, right? So this is how the round part is bladder and this part is posterior urethra. Okay. So this is a keyhole sign, just like the keyhole it is shown. So it is an ultrasonographic sign in boys who is having, yes, posterior urethral walls, right. So it is seen in boys who have posterior urethral walls, right. That one line is enough for you, right. Now this is how you will be measuring the abdominal girth, okay, during second trimester, okay. So you have to visualize all the structures seen here, like you should be able to see the portal sinus, umbilical vein and fetal stomach, okay, and it should be exactly round in shape, okay, abdominal girth. And if you see here, the umbilical vein is coming here and portal sinus is coming here, okay. So if I trace this, you are able to see an appearance which is like a hockey stick, right. So this sign is called as hockey stick sign. Fine. So this is one picture where we are measuring abdominal circumference during second trimester of a fetus, right. So you should be able to visualize all the structures shown here, like you will be able to make out the portal sinus, the umbilical vein under the fetal stomach, and the abdomen should be exactly round in shape, okay. So it should be visualized like this. And if I trace the umbilical vein here and the portal sinus here, you are able to see a hockey stick like structure, like. So this is known as hockey stick sign. So the importance of measuring abdominal circumference during second trimester is that it can assess the gestational age in second trimester and third trimester, and this is one of the important parameter to know about IUGR also, right. So in second trimester, we can use biparatal diameter or head circumference or femur length or even abdominal circumference to assess the gestational age, okay. Whereas in first trimester, what will be using to measure gestational age? It is going to be a crown rump length, okay. It is going to be a crown rump length, that is CRL, and obviously which is more sensitive, yes, it is going to be a crown rump length. Something made early is better than done late, right? Yes. So let's discuss about some Doppler images now. Okay, so this is an umbilical artery Doppler. So this is a normal waveform. Okay, so you should understand that while doing umbilical artery Doppler, you will be able to see a peak systolic velocity as well as an end diastolic velocity like this. Okay, so this is a end diastolic velocity, a peak systolic velocity and end diastolic velocity. Okay, so this is how a normal umbilical artery Doppler will look like. Okay, and why? See, umbilical artery Doppler is very important to find out the cases which are high risk, like if to find whether there is FGR or not, or whether there is severe preeclampsia, and who can have oligohydramnios, and in case of postdated pregnancy, like that. Okay. Now this is one picture where there is peak systolic velocity, but you are missing out the end diastolic wave, right? So this is absent end diastolic velocity in the umbilical artery. You have to know that if end diastolic velocity is not seen, then the fetus is compromised. Okay, and death of the fetus can be expected within 1 week. Okay, so you have to offer them daily Doppler. Daily Doppler should be offered, and you should offer them corticosteroids if they are less than 34 weeks of gestational age, and even if less than 32 means you have to offer them Maxil for neuroprotection as well. Clear? Right. Now this is another picture where you are able to see the peak systolic velocity, but the end diastolic velocity is coming on the other side of this baseline, right? So this is reversed end diastolic flow. Okay, this is what? Reversed end diastolic flow, and if you are able to see this reversal means then the fetus will die in another 1 to 2 days. Okay, so urgent termination is needed, and in this case no need to give neuroprotection at all. Okay, so maximum at least you should cover your corticosteroids at least. Okay, it's not cesarean section, it is corticosteroids at least you should get. And if it is less than 32 weeks means what you will do means you will go for a ductus venous Doppler. Okay, suppose if ductus venous Doppler is going to be normal, then you can continue for few weeks by doing daily Doppler. Okay, suppose if it is abnormal means you will terminate the pregnancy immediately. Is that clear? Right. Now, my point here is absent end diastolic flow is seen means you have to terminate the pregnancy by 33 to 34 weeks. And if there is reversal of end diastolic flow, then it should be terminated by 30 to 32 weeks. Clear? Right. Now, this is a picture of uterine artery Doppler. Uterine artery Doppler, the important one finding they will give you is the diastolic notch. Okay, so this notching in the diastolic area, you will be able to see this notching. What is the significance of this diastolic notch? Yes, it suggests there is preeclampsia in the patient, right? So, at 20 to 24 weeks, okay, if you are able to see this diastolic notch, then it predicts the development of preeclampsia, right? It predicts the development of preeclampsia, as well as because of complication of preeclampsia, the fetus will also go for fetal growth restriction. Okay, if this is seen, what you will do means you will offer her serial fetal biometry and umbilical artery Doppler from 26 to 28 weeks, right? And one more point I want to add here is usually this uterine artery Doppler to find diastolic notching is done between 20 to 24 weeks, 22 to 24 weeks maybe normally, okay. But if sometimes you can offer even at 11 to 13 weeks to diagnose early preeclampsia causes. Okay, if there is if the mother is high risk, you can even advise her to go the scan by 11 to 13 weeks also, right? Yes. Now see this picture. What does it show? It is showing a big baby, right? A big baby. It is a baby with macrosomia, right? It is a baby with macrosomia, right? Now, what is the definition of macrosomia? When the weight of the baby is more than 4.5 grams. This is according to your ACOG. But for Indian setup, when the weight of the baby is more than 3.5 kilograms, okay, so it is kilograms, then we'll be considering it as macrosomia. Okay, you have to know that whenever macrosomia is suspected, the most important condition you have to rule out in the mother is, yes, diabetes, right? So, it is diabetes you have to rule out, and most importantly, this will be your pre-gestational diabetic mellitus than your gestational diabetes mellitus, but yeah, it is also possible in your gestational diabetic mellitus, right? And remember, in diabetes mellitus, growth restriction, okay, that is fetal growth restriction is also possible when the mother has vasculopathy, right? It's not always you get big babies. Yes, you can also get small babies when the mother is having diabetes, right? Now, when the diagnosis of macrosomia is made, it is usually made during 3rd trimester. What happens is there is maternal hyperglycemia that will lead to fetal hyperglycemia, and which will promote more insulin secretion in the fetus, and we know insulin also promotes somatic growth. So, there is excessive somatic growth. Okay. So, other hormones like your insulin like growth factor 1, 2 and epidermal growth factor and also leptin, all these can play a role. And one more important point that is adding to obesity is there is transfer of free fatty acids. So, that will increase the triglycerides and that will result in adiposity. Okay. So far we have been discussing only about maternal diabetes, but what are the other causes that will lead to macrosomia? So the other condition can be maternal obesity itself. Okay, this is an independent risk factor, and a baby can be very big when it is a post-matured baby, and excessive weight gain during pregnancy is also another cause. Okay. So the most important problem that we encounter with a macrosomic baby is shoulder dystocia during delivery, and after birth it is going to be your hypoglycemia, right? Yes. Now I want to talk about two additional things here, like your values on IAD-PSG criteria. Okay, so IAD-PSG criteria, you will be offering 75 grams of oral glucose tolerance test after overnight fasting. That is very important. After overnight fasting. Okay. So, and after giving this, the plasma glucose values will be checked thrice. Okay. So, one at 0 hours and another at 1 hour and another at 2 hours. Okay. If the plasma glucose value at 0 hour is more than or equal to 92 milligram per deciliter, and at 1 hour if it is more than or equal to 180 milligram per deciliter, and 2 hour it is more than or equal to 153 milligram per deciliter. Okay. Then what is diagnosed? Yes, GDM is diagnosed, right? And the next one is about your DIPSY criteria. So this is also important. Here we are not considering the fasting status of the woman. Anytime she comes, we are going to pick her up and we are going to give it to her. And this is very important test that is given in Indian setup, because catching people with overnight fasting and asking them to come at a scheduled period to follow IAD-PSG criteria is very difficult in Indian scenario, right? The cutoffs and DIPSY criteria are when 2 hours OGTT value is more than 200 milligram per deciliter, then it is diagnosed as diabetic mellitus. When it is more than or equal to 140 milligram per deciliter, then it is diagnosed as GDM, and when it is more than 122 milligram per deciliter, then it is diagnosed as decreased gestational glucose tolerance test. Okay, that is impaired glucose tolerance, right? So this is all about impaired glucose tolerance. Now see this baby. So what does the baby have? Yes. So this is a case of sacral agenesis. And what do you know about sacral agenesis? This is the most specific anomaly that a diabetic mother will have. Yes, this is the most specific anomaly in a diabetic mother, and especially it is a pregestational diabetic mellitus, right? So talking about the anomalies that will happen with the diabetes. Okay. So, usually in pregestational diabetic mellitus only, you will be having congenital malformations, okay, not more in gestational diabetic mellitus, right? And the most common system that is affected is CVS more than CNS. And in CVS, the most common anomaly is going to be your ventricular septal defect, and the most specific one, this is most common, and most specific one is TGA. Whereas in CNS, it is going to be your neural tube defects and especially your sacral agenesis. Sacral agenesis is the most specific anomaly in case of diabetic mother. Is that clear? Right. Now, see this picture. You are able to see a baby with midline hypoplasia, nasal hypoplasia is there, midfacial hypoplasia itself is there, right? And you are able to see there is short proximal limbs and short digits as well. Okay, so what do you think this is? Yes, this is going to be a warfarin embryopathy. Okay, this is going to be a warfarin embryopathy. This is also known as fetal warfarin syndrome or Dye-Sala syndrome. Okay, or Dye-Sala syndrome. So, what are the characteristic features you have in this syndrome? Number 1, you can have nasal hypoplasia. Number 2, you can have skeletal abnormalities. Then You can have short limbs and digits, that is brachydactyly. Also, you can have stippled epiphysis, which is a classic finding here. Okay, and there is increased risk of low IQ and neurological dysfunction in these people, right? So, warfarin embryopathy occurs in pregnancies where the mother is given warfarin more than 5 milligrams, especially in the first trimester. Okay. So, the use of anticoagulants during pregnancy should be known, and questions have come regarding this. Okay. So, you should know when to switch on and what to give when. Okay, very important one. So, let us discuss about the period of gestation. Okay. Then the anticoagulant you can give. Okay. So, up to 12 weeks you can give either low molecular weight heparin or unfractionated heparin. The point is we should avoid warfarin to prevent warfarin embryopathy. So, no warfarin during this period of embryogenesis or organogenesis, right? And after that you can put her on warfarin from 13 to 36 weeks. Okay, you can say a green signal to warfarin. Okay, then after 36 weeks and till delivery, till just before delivery, okay, till just before delivery, you have to put her again on heparins. It is low molecular weight heparin or unfractionated heparin. Okay, and this will be started after 6 hours of vaginal delivery or 24 hours of cesarean section. You can restart anything, say warfarin or low molecular weight heparin or unfractionated heparin, like that. Okay, so this usage of anticoagulants is also important for you. Now, seeing this picture, you will be knowing that there is the foot and the hands are directly attached to the trunk, right? So, this condition is focomelia. Okay, so there it is a rare disorder where there is absence of proximal aspect of extremity. Okay, so the drug that is causing this condition is thalidomide, right? And this picture, you are able to see a low nasal bridge with minor ear abnormalities. There is indistinct philtrum, there is micronathia, epicanthal folds, short palpebral fissures. You have a midline face with a short nose, and finally you have a thin upper lip. So, this is characteristic features of, yes, fetal alcohol syndrome. Okay, so these characteristic features of fetal alcohol syndrome. Okay, and in addition to these facial features, they may also give other clues like microcephaly or intrauterine growth restriction, right? Yes. Now, seeing this picture, you are able to see that there is, the hand is seems like it has been tied with a thread, like. So, this is going to be a amniotic band syndrome. So, this occurs, mostly the reason is not known, but some say this may occur due to early rupture of amnion in pregnancy. Okay. So, because of this, the amnion will be found as a loose strands that will be tightening around the developing organs of the fetus, and so these constrictions are caused, right? Yes. Now, this one picture is also important. This is about your parter phases. How will be your parter phases? You will have low set ears, you have a beaked note, there will be prominent epicanthic folds and downward slant eyes. There will be pulmonary hyperplasia because of respiratory, that will be causing respiratory failure, and you will have limb deformities as well. Okay, so why this is happening? So, there is bilateral renal agenesis or bilateral multicystic dysplastic kidneys that will be causing reduced fetal urine excretion, and that will be resulting in oligohydramnios, and that will be compressing the fetus as such. Okay, so this is Parter syndrome, right? Now, let us discuss about some of the drugs and the teratogenic effect it causes. Okay, so we are going to discuss, repeat one second. Now, let us discuss about some teratogenic drugs and the defects which it causes, right? So, your methimazole causes cutis aplasia, right? And next, it is your methotrexate, it causes cloverleaf skull. Diethyl stilbestrol causes clear cell adenocarcinoma or a T-shaped uterus and also hypospadias in the male fetuses. And then anti-epileptics can cause typical facial features, and there can be hypoplasia of the digits, and one anti-epileptic, especially phenytoin, causes fetal Hayden-Toyne syndrome. Okay, phenytoin, fetal Hayden-Toyne. Okay, so this thing you have to remember. And lithium causes Epstein's anomaly. Angiotensin converting enzyme inhibitors as well as angiotensin receptor blockers will cause fetal renal hypoperfusion. One more drug, that is indomethacin, causes premature closure. Okay, it causes premature closure of ductus arteriosus. Okay, so all these effects should be known. Okay, all these have been asked in your exams, right? Yes. Now, I hope you will be able to make this out. Yes, this is a ring of fire sign, right? So, this is a ring of fire sign. So, this signifies that there is a hypervascular lesion, okay, and there is peripheral vascularity, okay, that is seen on color Doppler. And this ring of fire sign can be seen in two conditions, okay. Number one, it can be your ectopic pregnancy, that is you suspect mostly, but the other condition in which it is most commonly seen is corpus luteum, okay, corpus luteum. So, this is the most common condition where you see ring of fire appearance, okay. So, let us talk something about ectopic pregnancy. So, ectopic pregnancy, most common site of ectopic is fallopian tube. In the tube, which is the most common site, again it is going to be your ampulla. You have so many types of ectopic. It can be cervical ectopic, abdominal ectopic, ovarian ectopic and so on. Okay, we are not going to discuss about ectopic in detail here, but the management of ectopic I want to discuss. Okay, suppose let us discuss about the management of ectopic pregnancy. Okay, so it can be medical or surgical. Okay, I am not going to discuss this in detail, and remember the medication we can give is methotrexate. Methotrexate is a folate antagonist. Let us see the contraindications where you cannot give methotrexate alone. Okay, so contraindications to medical management. So, when there is rupture, when the mass is more than 3.5 centimeters, when there is fetal cardiac activity seen, or beta HCG is more than 5000 milli international units per milliliter. In all these conditions, you cannot give medical management, you have to go for surgical management. Okay, what is the most common surgical management you have to offer? It should be salpingectomy. Okay, that is removal of the tube as such. Okay, this is the treatment you have to give. Suppose if they give in clinical question like the patient already had one ectopic pregnancy and her right tube was removed. Now at present she is being taken for surgery. What surgery you will offer her? You will remove the other tube again? She is not having any children. That means what you will offer? It is not salpingectomy this time. This is salpingostomy. Okay. So, previously damaged tube or previously removed tube, in that cases it is salpingostomy, where you will put a hole, okay, just a hole will be put and it will be squeezed out and the tube will be left as such, okay, for future pregnancies, right? Yes. Now, what is this one? Yes, you will be able to make out, right? So, this is molar pregnancy. So, what is the sign? This is snowstorm appearance, right? Now, let us see something about molar pregnancies. You have two types of molar pregnancies. One is your complete mole, another one is partial mole. A complete mole is formed when an empty ovum is fertilized by a sperm and it goes chromosome duplication. This is one possibility. Also, a complete mole is formed when an empty ovum is fertilized by two sperms, that is dispermy, okay, and it can become 46XX or 46XY, okay. So, these are all the possibilities of developing complete mole. How a partial mole is formed? The ovum is not empty here, that is the point you have to get. The ovum also has chromosomes and either there will be dispermy or there will be chromosome duplication of the sperm, right. So, that will result in a triploid chromosomal number for a partial mole. Is that clear? Right. Now, let us see the difference between complete mole and partial mole. The pathogenesis for a complete mole is paternal in origin, okay. So, as I told, ovum is devoid of any maternal genome, is fertilized by either one sperm that replicates or it is fertilized by two sperms. And in case of partial mole, the genetic material is reserved from both the parents, okay. Normal ovum is fertilized by two sperms or occasionally it can be fertilized by diploid sperm also, right. And the karyotype in case of complete mole is diploid, that is 46XX or 46XY, whereas in case of partial mole it is going to be triploid, that is 69XXX or 69XXY or 69XYY, anything like that, okay. And in some cases it can be tetraploid or mosaic also, right. Pathology, there is absence of any embryonic material, okay. It is a complete mole because fully made up of mole, whereas in case of partial mole, a small amount of embryonic material can be present. And trophoblastic proliferation is diffuse in case of complete mole, whereas it is said to be focal in case of partial mole. And villus scalloping, this is very important picture that is absent in case of partial mole, but it will be seen in case of partial mole. And clinical features, the uterine size will be large for dates in case of complete mole, whereas in partial mole it will be small for dates. And thecal lutein cyst will be most commonly associated with the complete mole when compared to partial mole. pH is also associated with the complete mole, and postmolar GTN transformation is also mostly seen with complete mole, and immunostaining with the P57 is positive for partial mole, okay. So, other risk factors are associated with the complete mole, but staining, okay, positive for positive, P for P, okay, positivity for P57 is seen with partial mole. Is that clear? Right. Now, this is a picture where you are able to see the products of conception, a complete hydrated form mole. So, profuse proliferation of grape-like fluid vesicles, that is representing expanded chorionic villi, okay, some vesicles are seen, okay. And here you are able to see vesicles as well as a fetus is also attached. So, this is a partial mole, right? Yes, but still we are not done with obstetrics, we are yet to go, right? So, this session will be continued in another part. Until then, take care, happy learning, keep going and bye-bye.